I'm Patricia Thaine, co-founder of Private AI, and this is the Data Frontier podcast. Here we explore the frontier of data innovation where unstructured data meets real-world applications. Each episode brings together builders, engineers, data scientists, product leaders, and domain experts who are shaping the future of intelligence systems. From NLP and privacy to interoperability and AI-driven workflows, we unpack the tools, challenges, and breakthroughs transforming raw data into smarter systems, faster insights, and better solutions. Super excited to have Dr. Travis Bias here with us today. He is the Deputy Chief Medical Officer for the Health Information Systems business at Solventum, formerly the 3M Healthcare business, and a family medicine physician. Thank you so much for joining us, Travis.
Patricia, thanks for having me. I appreciate it.
Yeah, really excited to dive in. First question for you, because this is one of the main things that Solventum does, and as a physician, I'm sure this is something you think about a lot. Which AI tools are clinicians actually using on their day-to-day?
Yeah, there are, of course, a whole host of AI tools that physicians have been using for many years. And on our space, we are focused a lot around making it easy to completely and accurately capture the complexity of a physician's patient population most efficiently, ideally within the first time around in the chart. And so we use a variety of AI tools from rule-based systems that have turned into machine learning and now generative AI systems that are supporting this end. And so we have front-end speech recognition tools grounded in machine learning capabilities that improve for the end user the more they use it. We have ambient documentation solutions that, of course, is like the hot thing, AI scribes, people call them, that helps to listen into a patient-physician conversation and then leverages generative AI to create a draft note for the physician to edit and sign. And then we have other systems that are grounded in a natural language processing engine that we use to then basically read the note in real time and identify gaps in documentation that might support a complete capture of the patient's picture. And so the more you can accurately and completely capture a patient's complexity, the more you can accurately pay for their care, and the more you're able to risk adjust quality measures or quality outcomes that might be reported for a variety of ends. And so that can support quality improvement and safety initiatives for the organization. So yeah, a variety of things we could talk about.
Okay, that's super interesting. Um, which ones of these systems do you feel are the stickiest?
Well, right now, I do think these ambient documentation solutions are super exciting. And to answer the sticky question, I think you have to talk about the end users and how a solution improves their workday. And I think there are many different technologies that physicians, at least, have seen and felt over the last 15 years that really top down, like leadership of an organization or maybe a ministry of health or something that says, here, use this technology. And physicians have said, this is like another thing, another app I have to log into, another thing I have to learn to use. And so the adoption is really quite low because it comes from like a mandate. But these ambient solutions from small to large organizations, physicians, once ChatGPT came out in fall 2022, and these solutions popped up within months, physicians, I think, very quickly saw, oh, wow, this is going to absolutely be a game changer in my workday, because instead of me having to type in word for word or dictate word for word in a chart, I now have generative AI putting a first draft in front of me within seconds after talking to the patient. And it's just very obvious to the end user why and how this is going to help make their workday easier and more enjoyable. So it's freeing them up from some of the clerical tasks in the electronic health record to then focus on the patient in front of them and focus on more complex tasks that we actually went to medical school to perform. And so I think those are the solutions that you're going to see. You've seen already super high adoption rates from clinicians because I think it's just so obvious how it improves their workday.
Can we double click on the trust aspect of that?
Yeah, so I think early on, we can show the full transcript, which in a 30-minute conversation between patient and physician, most physicians are not going to take the time to scroll through an entire transcript. But we can also show in the draft note, you can scroll over segments of the note and see exactly from the transcript where that came from. Because, generative AI, and Patricia, you could probably explain this to your audience better than I could, but generative AI can confidently hallucinate information, but can also omit key information, which both of those things are terrible in a health record for a patient. And so early on, to build trust with clinicians, we wanted to have this kind of evidence generation where we could scroll over it and really map exactly in the transcript where that claim came from. So if the patient said that they tripped and fell and hurt their left ankle, you can scroll over that and say, oh yeah, she did say left for sure, and it's not the right, or it's not the left shoulder or something, completely different. And so you can see that. But I think early on there was a lot of trust building, and that was on some like simple, very product specific, solution specific things. I think now the trust building is moving more towards broadly, okay, I'm using AI in a lot of aspects of my practice now, from ambient documentation to CDI, clinical documentation integrity. So if I'm getting nudged on information like, hey, I said the patient has chronic kidney disease, can you be more specific what stage of chronic kidney disease? Because that changes the treatment. Those types of CDI tools are built on different types of AI. And then from like all the way down to like sepsis prediction, is this patient have early signs of sepsis where they might need to be treated more aggressively with a different treatment regimen. So different AI tools built on different models are now being put in front of clinicians. So I think the trust is having to be built across those tools at maybe a practice level or an organization level. I think that's where the complexity and all the governance talk probably needs to be focused right now to build trust that physicians know when they're switching from one tool to the next. How is it trained? How reliable is it? How am I meant to apply it? What is my role as a human in the loop for this specific tool? And I think that's one of the big challenges right now that different vendors have when they go to a different customer sites and apply their solutions to different use cases, being super crisp and clear on like what the clinician needs to be doing with their specific solution.
How do you, in such situations, get feedback from clinicians?
Well, there are many different stages, right? Obviously, in a product building stage, before you even go to a customer site, any new product or any new feature that we're building in, we get a variety of types of feedback. But that best feedback comes from just working alongside the clinicians that are going to use the product, right? So we're already in multiple large health systems across the U.S. We'll focus on the U.S. example, where we have solution advisors that, with a lot of our products from speech to ambient, the solution advisors or adoption specialists was an older term we used, who really go in and can sit alongside physicians and understand how exactly they're using our product, what workarounds have they already built into their EHR workflows, and how are they plugging in our solutions, and what else are they trying to do in addition to that? What can we add in that's actually going to support them? And so I think being clear on, again, the workarounds they've already built, but the problems they're trying to solve, the efficiencies they're trying to build into their workday. And so that kind of feedback, that's kind of like post deployment feedback, I guess, what I'm describing. But obviously there's pre deployment feedback and just the kind of the product development stage, where you really have to get a diverse set of feedback from advanced practice providers like nurse practitioners to physicians of different specialties, because their charting is very different, right? Like orthopedic surgeon has a very different charting workflow than a primary care physician like myself. And so these are the things that we try to take into consideration, because we're at large organizations that have huge multi-specialty practice groups, sometimes thousands of physicians. So trying to meet those needs can be a challenge and requires regular feedback, especially those that are using multiple vendors, right? We have to understand how are we working alongside complementary vendors in the EHR space, because everyone wants to be in that electronic health record right in front of the physician. Everything's just as important to each individual vendor, but then the clinical informaticists or the CMIOs at those organizations are having to kind of sort through all those and help their physicians understand how these solutions, again, are meant to be used maybe in concert to improve efficiency. So that feedback, I think, is critical. I think that adoption process is super important. I've stuck my nose in a lot of adoption and implementation strategy conversations, simply because there's a lot of expectation setting you can do upstream from the initial implementation and from the first 18 months of the rollout to really get it right. And that actually prompted me to do a change management certification. I'd heard a lot about change management, and it's a lot of frameworks that clinicians kind of naturally understand. We would naturally think about, we have a basic empathy for our colleagues. If I'm going to deploy a product, we need to kind of set the stage before we turn the light switch on green that the product is working. We have to really help them understand. You mentioned the stickiness. One of the change management frameworks is desire. The physician has to want to use it before you even implement the tool. So I think there's super basic frameworks in the change management world that can actually help us get the implementation right and ensure adoption and feedback processes are optimal so that the ROI is the most you can actually get, both financial but also qualitative. And we can talk about that.
For the orchestration that you mentioned with tools that are outside of the EHR, are there any that you find are used in conjunction with yours more frequently?
We have worked with some of our customers for years, sometimes decades. We work to try to ensure that that orchestration happens as seamlessly as possible because we don't want to be disruptive to the clinician. We don't want to be disruptive to the CDI team or the coding team. And I think the further you get out from being integrated in the electronic health record, the harder it is to convince an organization of the use case, and it has to be compelling to the end user to keep adoption where you want it.
With regards to the physician feedback that you're gathering, you said there could be thousands of physicians that you're getting this feedback from. It is before the product launch. It is also continuous after the product launch as well.
There are various ways, right? There's the more automated ways that are just through the product. Hey, did this work well? Did this not work well? Here's a place you could put feedback in anytime. Building in back to the people pieces. If you've got the right physician champions or whoever the leaders are that are going to be helping to roll this out at our client site, that is a way to escalate product concerns from the get go to where there's a single point of contact at the organization that's helping us to communicate these messages because the messenger is sometimes just as important as the message, right? I can go as the vendor physician leader all the time, but really physicians want to hear from their own leadership, whether it's within their own specialty or at their own geographic facility location. Those are important escalation pathways to get that feedback communicated. So that's a kind of one avenue. I mean, the other is through these solution advisors that I talk with that are a team that we have that support all of our customers with our products to make sure we're getting regular feedback. Because again, we want to be solving really important problems. We don't want to be solving fringe problems that our tech teams might think are cool and fun to build. And I'm good friends with those guys. But that feedback mechanism is critical back to gaining trust. If people know that their feedback is being heard, and then they see the closed loop proof of, hey, we're building something that's actually going to start to target the problem they're trying to solve.
Do you find that the interoperability issues have gotten better or worse over time?
So that does seem to be getting a lot better. And that's probably, it sounds like a very US centric question. I mean, I think globally there's very different needs, like different provinces in Canada, for example. I think there's a very different need there. Within the US, it's getting better. The last several years, obviously, there have been governmental efforts around interoperability and many efforts across the system from providers to payers to tech vendors like ourselves. The challenge is still getting the right information in front of the clinician at the right time to make the decision, surfacing that key information. And like, it's not only a question of like, do we have the information in our ecosystem, but can we surface it in the right way? If it's in a 200-page PDF, that's not super helpful when I'm seeing a patient every 20 or 30 minutes, maybe every 15 minutes is in a GP practice. It is getting better. It is easier to grab the right information at the right time, but it can be a fragmented ecosystem depending on where you're working in the US. We're still moving in the right direction. I just don't, from what I can tell, it's not as fast as most people dreamed up 8 to 10 years ago. We're definitely getting there. And I think it's because patients are demanding it, right? I mean, patients are like, why on earth is it so challenging for me to get my record on one app, on one phone, where all my financial information is super easy to tee up with facial recognition now. So healthcare feels like is kind of catching up when it comes to meeting consumer demand in the sense of getting all my data accurate and in the right place at the right time, and even in a place where I can get feedback on inaccuracies in there.
I'm going to follow that up with a build versus buy question.
Sure.
Are there any, can you give a comparison of when it is best to get a solution through Solventum or through a third-party vendor versus if you have a technical team in the hospital, when it's best to rely on your technical team to build something out?
If you have a local technical team who has strength and domain expertise and you know your local health data, you know your local health needs, the health needs in Austin, Texas are very different than in rural Wyoming, and very different than in downtown Toronto, I imagine. So I think there's something to the fact that your local IT teams may have some local expertise. And if they've got the technical expertise that you can build fairly cheaply and quickly, fantastic. I mean, do that. And I think now with all the vibe coding. I mean, I'm a family physician. I'm not a coder by any means, but all the vibe coding possibilities that are out there now, that just with natural language, I can build an application that might solve a short problem. I mean, that's super exciting. And that should provide a lot of strength and cost savings to organizations. I think the challenge becomes for an organization, back to what I was saying, trying to like wrap their heads around all these different AI models, all these different AI solutions. If the local team doesn't have the expertise or the knowledge around governance of those systems, how do I monitor post deployment if this AI model is drifting into something that's infusing even more bias into our health system? That would be awful. That is one thing that larger players like a Solventum bring to the table. We have that knowledge, right? We're interfacing with large customer sites. We're interfacing with large vendor partners many times, and we just have the teams and the expertise in some of those areas that allow us to build something maybe more quickly, but also to deploy something with a view towards compliance. I mean, I think compliance and risk is huge when it comes to payment integrity, and that's something that we've been focused on for decades.
So in part, it's how specific is your problem to your particular healthcare system or your particular hospital versus can it benefit from the large amount of feedback and iteration a company like Solventum is dealing
Yeah,
with?
I think that's very well said. And sometimes people ask us why we haven't done something a certain way, and it's like 'cause multiple customers steered us away from doing it that way, and this is why. And so I think
Mhm.
there are learnings that we can pass on certainly to a next iteration of customer sites, but it's also because we have content expertise from people who worked as actual coders, people who've worked as clinical documentation integrity specialists, people that have worked in the clinical spaces, and so all of us working together can say, hey, Actus and AHIMA in the States, like these are the coding and CDI guidelines. These are things you can and can't do. So from a compliance standpoint, a risk standpoint, and a payment integrity standpoint, we would steer you away from this. This isn't just something we just decided to build in the last couple of years because we can vibe code it. It's something that grounded on decades of experience. Sometimes this is what we really can and can't do to stay in compliance with either governmental entities or commercial payers or what have you. And that's a really important piece.
Are there any products that you could talk about that weren't sticky at all?
Grounding on our coding expertise and our clinical documentation integrity and around population health capture, we had a solution that would capture codes pretty accurately and put things in front of clinicians. And it was within our application that sat on top of the EHR, but it couldn't put those exact codes in the visit diagnosis field or in the problem list field in discrete fields in the electronic health record. So, right back to our original discussion about what makes things sticky and how we integrate with EHRs. And so, in some EHRs, we can put those directly in discrete fields, and others we can't. That is a challenge that we can do that through some partners potentially, but it was that last mile that really prevented us from being successful. And we had some really good faith customers that really tried to make it work. But ultimately, physicians were like, if you can't put that in those two discrete fields, there's no point in purchasing this, no matter how accurate it may be. That's one really key lesson learned for me. And maybe that's a very physician facing answer, but anything that is going to require physician action or clinician action of any kind, clinician maybe behavior change to look at a different field in their user interface or click on one more click. Physicians count every click that it takes to enact something. If you are adding to that or you're not taking much away, to ask them to use a new solution, it's just not going to work. And we've had some things that have fallen flat because of that last mile.
Sounds like another interoperability issue.
I think so. There are just so many places where you need to exchange information between organizations, between vendor and organization, between different parties. That is a major challenge that nowadays there are enough integrators out there, third party vendors that can help do that. But yeah, the more friction there is to gather the right information, and put it on the right place at the right time for clinicians, the more risk you have of duplicating costly lab orders, imaging orders, treatments. And so the more we can bring together the right data elements in the right place at the right time, you will just have better and better care and ultimately save money for those that are paying for it. So I would imagine that's only going to get better. I mean, you see a lot of these consumer facing apps now from OpenAI to Anthropic to others really getting into this healthcare space because they know there's a lot of area for opportunity there. And we definitely see that on the back end when you see the documentation that leads to ultimately coding and pop health data capture. You have to have that right information or the documentation is still not going to improve.
And speaking of that right information, have you heard of open banking?
No, tell me more.
Oh, you have not? Okay. Basically, open banking is a, I guess you could call it a regulatory requirement, a framework in the UK. It has been a thing for a few years now, and it's about enforcing shareable information about individuals so that smaller players can pull that information and then make it make it usable in their products. And the idea there is that it does enable innovation. It enables non-oligopolies. And I haven't heard too much about something equivalent for that for health. Of course, there's fire and open air, but these are not regulatory enforced interoperability standards. There doesn't seem to be any discussion about enforcing giving patients their data or giving organizations data upon patients' request from various systems in an easy way.
I mean, when you were originally describing that, I was like, wow, you could apply that to the EHR world in the US. What the exact story you're telling, because I think that's what ultimately people want to do: open up the information, make it available, make patients able to decide which information they're giving to which entity, just the click of a button, signing an app, Face ID. I mean, you're right. I think there are several legal cases moving through. I'm not. I don't pretend to be an interoperability expert or legal expert. I can introduce you to people like that. But there are a couple legal cases moving through right now that are very much about information blocking, making sure the information is flowing when appropriate, when used for appropriate end use cases. That's one of the big challenges now. It's sometimes between vendor and organization rather between patient and organization, or patient and vendor. Maybe it'd be easier to be starting with pushing for regulatory clarity around how patients are getting their own information onto their devices or applications, or whatever they choose to use. And so, yeah, early days, there's still a lot of uncertainty around what the U.S. government's posture is going to be from a regulatory point of view around some of the interoperability pieces. But it's one of those things that clearly it's a patient demand thing, clinician demand thing. It just is unclear to me how heavy-handed HHS is going to be within the U.S. as far as pushing for that. So yeah, I think you're right. I don't know if there's as much of initiative, but I do think there is a huge appetite in the current administration to democratize access to your own health information. Like that seems like something to be very palatable to the current administration. So I'd imagine you'd see targeting any kind of severe information blocking to prevent the oligopolies you're talking about.
Some of the reasons I've heard against open health data is really around the privacy and security side of the data.
Banking data probably has a social security number and a lot of really sensitive stuff there. But you're exactly right. I mean, the health data is a little bit different. And as far as having permissions, I mean, now you go on any website and you click, allow the cookies, and so we give up a lot of our privacy without understanding exactly who all we're giving it to. Maybe there's a third or fourth party downstream that we don't know we're granting access to my browsing data. And so I think that's a very fair concern to have around health data, because you just want it to be used for improving communication between their different clinician types, between GPs, specialists, between hospitals and their GPs, and maybe even between their pharmacies and GPs and the payer, whoever's paying for. So there's tons of opportunity there. Obviously, you'll see healthcare hopefully catching up to the financial industry and other industries, other sectors. COVID, the pandemic, I think that was one silver lining, if you have to find one, is it really showed us all we can do remotely or with technology if there's really a strong need and strong pull for it. I think patients were finally like, why on earth is this so challenging to get tested for COVID, or to get my result on my phone, or get my vaccine status on my phone so I can get on a flight or go to a restaurant or what have you. And so at least the pandemic highlighted a lot of areas for opportunity that it seems like plenty of vendors are moving into.
Does Solventum have any patient-facing products?
Yes and no. I would say majority of it is not patient facing. The one area that we are focused on is around pivoting the clinician's documentation to patient facing instructions. And so the beauty there is, in the past, I would write my progress note that was internal, meant for me and my clinical colleagues. And then I
Mhm.
would have to write very separate patient facing instructions in lay language that I thought they would understand. And then if it's a patient, maybe English wasn't their first language, I'd be like, well, translate it with a family member and hopefully you'll understand it later. Right. And so
Mhm.
that's not great for the patient. It's not a good experience. And so it leads to a lot of patients just kind of not doing what you were hoping they were going to do as a clinician. And so now generative AI is amazing for this, right? Where you can take the clinical note that I've written, I can just write one note. And from that, you can create derivative notes of many kinds, right? You can pivot my note to be a message to the cardiologist.
Mhm.
My note can be a message to maybe the ED or A&E physician if I'm sending the patient to the emergency department. Maybe you take my note and create, again, those patient facing education materials at their reading level of whatever education level they stopped at and at their preferred language. Multiple solutions out there can do this with high accuracy. And that is a huge patient pleaser. So I think from that regard, that's probably the most patient facing example that I can think of where patients can then take that information, digest that information, and make maybe complete all the tasks that the physician was hoping they would complete as far as please go get your blood drawn, please go get your chest x-ray done, please go pick up your medication at the pharmacy, and try to exercise one more time a week than you typically are. Those kinds of things that if I put it in a laundry list in my own language, it may not be adopted and may not be used in the way that I was hoping.
And that's a really interesting example of orchestration with other tools. You've got the physician facing expertise orchestrating with the patient facing expertise, and one can inform the other.
Yeah. Well, and probably in some of the spaces you've worked, maybe there's an intake message from the patient. You could be using generative AI to tweak the responses, right? There are a lot of in basket response use cases for generative AI where there's even studies that show that those responses are seen as more empathetic and higher quality than a human message back to the patient. Because I'm busy, I've got 100 messages in my in basket. I'm not going to write
Mhm.
a 3 paragraph response about your runny nose, most likely, right? But generative AI has all the time in the world to write a lengthy response about how awful and annoying your runny nose is. And here's several things you can try and again, respond in your own language. And it is very exciting. And all that doesn't take any extra time. I think that's the thing that's really exciting is that we've got a lot of solutions now that can not only do this with higher accuracy rates that will improve health behaviors, but it also doesn't add any more time. In fact, it takes lots of time off of clerical tasks that I would have to be doing in the electronic health record that now I don't have to do. I can move on to a task that is going to maybe have a higher impact on that patient's health. I can go dig deeper into the reason that they're waking up at 3 a.m. with headaches, or that, maybe I can dig into the reason that they've got anxiety out of nowhere in the last 4 weeks. Maybe there's an underlying cause to that. Instead of me just kind of, okay, let me order some blood work and move on to the next patient because I've got to type a bunch of notes at the end of the day. Well, now I can be focused on digging deeper with that patient or serving a broader number of patients, right?
Mhm.
Potentially, if I've got some of these other tasks off my plate.
Do you have any hot takes around ChatGPT Health and maybe some of these tasks?
Yeah, I think I could see so many benefits of this for patients, right? They're going to be able to collect their own information, to query and ask a bunch of questions of their own information, to have maybe long conversations to explain to them why something
Mhm.
is or is not a big deal. Back to your interoperability problem, it's got to have all the right information in the right context. That's one big gap that I see. One main challenge I see is that if you don't give, and I use Claude personally for a lot of strategic and creative work, and if you don't give it the right context, it might give you some answers that are not at all consistent with your own values and priorities. That's one big thing that I would hope most patients, I would advise them to, throw all your information in there, sure, but make sure you're giving it plenty of context. And this is what's really important to me. Maybe it's really important to me that I go bowling once a week. And if, as long as I go bowling once a week, that's all I care about. Okay, well then maybe that hip replacement is super important. For a bowler, you got to have hips that work. ChatGPT won't automatically know that about you, that bowling is super important. Or for Claude, for me, I'm traveling with my soon to be 2-year-old. So if I'm creating an itinerary, I can't take a 24-hour flight. I might be willing to pay $100 more to do the nonstop flight, or I might want to go somewhere that has a certain type of weather because the 2-year-old needs a certain activity. So I think those kind of context pieces are super important. I think new users to LLM based chatbots are not sometimes well versed in that. So I think that's going to be one thing that is missing, and some slight lab or abnormalities that might cause someone to have a panic attack. If you give it enough context, it might tell you, oh, that lab value is not actually a big deal at all. Or subtle abnormalities like a hemoglobin A1C that's barely elevated. Hey, that's a pre-diabetes level. And like you could actually take a bunch of actions to hopefully never be a diabetic as long as you did a few things. If you stop smoking, if you start exercising a little bit more, if you improve a few things about your diet, and ChatGPT's got all the time in the world to educate you on that. And so I think those are the exciting pieces, that you're really democratizing access to tons of health information that patients are clamoring for. And it's not just a random Google search. It is grounded on a little more information. There are going to be some rough patches up front where patients are given information that's inaccurate potentially or not in line with their values. We're just going to have to expect that. That's not a very hot take, but I think the context thing is super important because every patient's different.
No, it's super interesting. I really like what you said about it might not be in line with their values. At which point do their values actually make a difference to facts? And will that make a difference to usability?
Yeah, that's interesting. I hadn't really thought Say more about the usability part.
Their desire to use the technology, really.
I've got a great example for you. I had a 78-year-old man who came to see me. It was my first year out of residency. He came in and he started telling me a story about how he started noticing over the last several years that he had trouble swallowing because he has a mass in his throat.
Mm,
And it was really important to him to eat his steak. I was in Central Texas. It was really important for him to eat his steak dinner every night. But to swallow that steak, he had to lay on his stomach to swallow it. And of course, in my head, I thought, well, I'm not sure that's worth it to eat my steak. But this is like his one thing that he really enjoys. And the more he
mm,
described to me, and when I examined him, like I get chills thinking about that. I'm like, this guy has a mass in his throat that is surely an advanced stage cancer. This is not good.
mhm,
And he said, you know what? I'm not willing to undergo any cancer treatment. I'm not going to do chemotherapy. I'm not going to do radiation. I'm going to lay on my stomach. I'm going to swallow my steak every night. I'll be fine. And I realize it's going to lead to my passing. It's going to be terminal here in the next months, years, whatever it is. And he and his daughter actually got a lot of pushback and a lot of bad attitudes from nurses at the emergency department because you go in with a little trouble swallowing or breathing, and
mhm,
he would refuse to get admitted to the hospital, or he would refuse something that they wanted or leave against medical advice. And they would give him a lot of attitude, but that was not respecting his values and his wishes, right? And so if he or his family member would have to like put that information in ChatGPT to avoid getting a litany of like, oh my gosh, you need to see the oncologist, you need to do this. It would give this long list of things. He's like, I'm not going to do any of that. But
mhm.
unless you tell ChatGPT that, it's not going to give you that kind of output. And so I worked with them to get him an out of hospital do not resuscitate order signed. And eventually, when the time came, I got called in the middle of the night. It was one of the few death certificates actually signed out of residency because usually another type of physician would handle that in my community. But it was because it was what it took. It took me spending a little extra time with them to get that documented. But unless you're telling a chatbot that kind of information, it's not going to give you the type of advice that you might want, which is here are things to reduce swelling of a neck mass that don't involve chemotherapy or radiation. Here are ways to improve your swallowing capability in addition to laying on your stomach. Workarounds that he was figuring out that made sense to him, and ChatGPT could have given him advice aligned with his values, but only if they had input that type of context and information.
It sounds like a lot of the medical professionals weren't giving him advice aligned with his values regardless.
Well, he had not gone to a medical professional in 30 years and he landed in my clinic. And so
Okay.
as a young GP, I was like in shock initially. And then once he started talking to me, I was like, well, this guy seems of sound mind and I want to respect that. And I'm like,
Mm,
you realize we could diagnose it, stage it, at least you get a treatment plan and think about it. He was like, nope, I'm not going to specialists. It's not going to happen. But these are things that really take active listening, a lot of context. And I think some of the human judgment that is not part of these chatbots just yet, right? Like every AI piece you read is about how some say that AI is coming for all of our jobs. And then others say, well, AI is going to take some of these repetitive tasks off our plate and actually help clinicians be more human, and that human judgment is going to be a critical piece that's still needed for years to come until the bots truly come. Do you have a hot take on ChatGPT Health?
I need to know more about what data it's accessing. I don't have clarity around that. And it might be out there, it might not.
Well, but I hear it's spotty. Like I have physician friends that are posting about this on LinkedIn. It's still spotty. It doesn't have everything, right? Now this is back
Mhm,
to your interoperability challenge, right? So you might be able to easily pull from the one health system. If you've been seeing at one health system for 10 years, great. You've got a bunch of your data in one place. But if I've moved every 2 years to different countries, different cities, different states, it's going to be very hard to get all that in one place. And so
mhm.
I think it's going to be a challenge.
Absolutely. And there's the privacy challenge too. Even if regulations are tight around this, they can change. So what are they going to be able to do with your data?
Yeah, that's interesting. I hadn't thought about that because it will change. Obviously, the regulatory regime, both here in the states, we're definitely not anywhere close to where the EU or other regions are. But that's a really really interesting point. And the privacy, I mean, that's another major concern, right? Where I think they say they're not training on your personal data. So you have
And
to take.
and for now, insurance companies can't get access to that data, but
Right. Right.
regulations change. So I
Yep.
have several concerns around that. On the values front, I'm super interested in seeing, for example, there's a growing measles outbreak in the US, right? And clearly there are certain values that are not aligned with prevention. So where is GPT Health going to align with that? Are they going to not recommend preventative measures? Are they going to recommend how to deal with it post hoc? What sources are they going to use for this?
This is super interesting. So I think what you're saying is if I put in that I am absolutely against all vaccines or I'm absolutely against the MMR vaccine, there's a measles outbreak nearby. What would you advise me to do? Quick, ChatGPT. Like, are they going to say, hey, don't worry about it. You still don't need to get your MMR. Just stay isolated. Or are they going to push back and say, actually, multiple bodies recommend an MMR vaccine, especially if you're near an outbreak?
Yeah, exactly. And then what if you're also against isolation in addition to that?
I would imagine there's a place to build in. These are the key recommendations of bodies, no matter who you are. And this is what's aligned with your personal values. And hey, those conflict. But that is really interesting because I know that Claude commonly tells me what I want to hear. And
Mhm.
so as a geriatric millennial, we got a trophy for everything. And like now Claude tells me that, I'm doing a great job thinking about all these different things. And so certainly there's going to be an element of that in ChatGPT Health. Yikes.
Let's loop it back around to the kind of thing that Solventum is doing. Uh, in addition to providing physicians with the tools that they need, um, having interoperability or orchestration with potentially these patient facing tools. You do, if I'm not mistaken, also work on staffing, capacity, resourcing um, technologies. Is that correct?
So when I think about capacity and like staffing, maybe the workforce or anticipating what resources are going to be required to care for a population, what are really our core business is around capturing how complex a population truly is. It requires a few things. Much of that comes from the documentation, the electronic health record. So there are in real time while a patient's in the hospital or maybe recently discharged from the hospital, there's a clinical documentation integrity team that works to make sure I've fully captured that patient and how sick they are. So if that patient was in the ICU and intubated, we got to make sure there's an accurate respiratory failure diagnosis as granular as possible. That then goes downstream to the coding team who works on our coding software. That coding team makes sure that ICD-10 codes, so diagnosis codes, and then treatment codes, whether that's CPT or ICD-10 PCS or other treatment codes, those codes are then attached to that admission appropriately to then ensure that a grouping methodology like the APR-DRGs, so diagnosis-related groups, reflect how complex that one admission was. Or we can use those codes to then reflect how sick a patient population is, even marrying inpatient data and outpatient data all together.
Mm.
And so the goal there in my mind is to fully capture what kind of resources that population will require for the coming year, actually. So we work with payers, we work with ministries of health, we work with state, provincial governments. We work with a lot of different entities that are trying to use that data to allocate resources appropriately, but then to set incentives in the system. What are the payment systems? Payment incentives? How can I pay for value rather than pay for volume or pay for widgets? And so the more you've got accurate data and the grouping of that data, the more you can segment populations, the more you can stratify populations to target your most complex patients. But you need data to create all of these schemes, basically. What then you can do from that coded data, the more robust and complete and accurate that data is, the more you can see, hey, there's this population in downtown Oakland that is unhoused. And there is a huge issue there around housing. So if we were to somehow contribute our resources to improve housing for this segment of patients, we would probably improve their health and save a lot of money. Or, hey, this population lives in a food desert. And so we see a lot of codes or a lot of, even through NLP, where you can capture data around social factors like this. Hey, this population has trouble accessing healthy food options. Or this population has a transport problem. That's something a lot of health systems are targeting. Let's send Uber or Lyft to go pick up that patient, or send even better transport options to bring that patient to make sure they get to their specialist visit. But all that from that data, you can glean a ton of information and come to a lot of conclusions about that population. And then the payers, whether it's a private or commercial payer that your that employer-based plans are providing, or government-provided payment, you can just see that at the population level and say, hey, this population has a different need, and so we can divert those resources appropriately. Whereas the tech population, I used to work on Apple's campus in Austin. They have very different needs than those that are in downtown Oakland. I've taken care of both those populations. So those needs might be very different and might require very different type of resources. And so I think all that to be said, while we don't do necessarily workforce capacity planning, staffing models necessarily, we can say, hey, these are your trends looking back years. These are your complex patients. Those patients are planned admissions during these months, or maybe that your ED volume is going up during these other months. And so we can use that coded information from a population health level to lead you to a bunch of different conclusions to shorten your length of stay, improve efficiencies, and thus plan for workforce needs going forward.
Do you have any examples of employers or providers or government acting on that information?
Absolutely. Yeah. There's tons of examples of that. I think of during the COVID pandemic early on, we had the regional government of Valencia in Spain use our clinical risk groups, which is a methodology that allows you to risk stratify a population down to the individual level. So you can literally rank order. These are our sickest patients in this region, and these are our least sick patients. And then they took that top chunk and said, let's contact them and make sure they have PPE, make sure they have masks, make sure they're isolating appropriately. So you can target those sickest and most vulnerable patients and ideally keep them healthy and keep them out of the hospital. That's a super simple use case,
Mhm.
but this is just one of many things that you could do with that. You could segment um, by disease state. So, hey, these are all of our heart failure patients. Let's call them every 2 weeks, and especially the ones that are the sickest of those heart failure patients. Let's call them and keep them out as part of our heart failure or prevention program. I know there's some regions that are doing that, and then there are employers that have used the data, and regional governments like Valencia as well, that look at this is where some of the highest pharmaceutical spending is.
Mhm.
And maybe there's an opportunity to target, hey, you're spending a lot on trade name drugs when actually generic drugs might do just as good. And so there are ways that you can look at that to not only look at pharmaceutical spending, you can look at specialist referrals, which specialists have different practice patterns, which hospitals have different practice patterns. So there's a lot that you can glean from that data and then act on that to really improve health, lower costs, and just make judicious use of our limited health resources.
You can even use it for some very targeted patient-facing recommendations.
Absolutely, absolutely. So that's we've got a really nice slide that really talks about, okay, we've got 9 levels of clinical risk groups, right? Your
Mhm.
sickest with multiple comorbidities, cancer, and your lowest, your least sick that are perfectly healthy. Well, the sickest, you might call them every week or every other day. Hey, have you refilled this medication? How are you feeling today? Can we get you some resources? Here's some education around just weighing yourself daily, watching your diet. Those least sick, the healthiest patients, let's send them prevention messages, whether it's through an app on their phone. There are a lot of efforts I've seen around this in Singapore, for example. They're using an app to really target people with prevention messages. Hey, what have you done to exercise today? How's your mental health? Have you taken a break from the screens to go outside and go for a walk? I mean,
Mhm.
there are very different tailoring that you could do and tons of automation that you could build in around that. But you have to know who those patients are, and you need a lot of really reliable population health data to be able to connect those dots, because otherwise you're just spraying out a bunch of information to a bunch of people, and it's not tailored or targeted. And I do think that's one thing that AI is just improving exponentially, is some of those tailored patient-facing education messages that I think the optimistic case for ChatGPT Health is that that's what's going to be used for, right? Is this education that's tailored to me, that is evidence-based and not based on a Google search.
And while you practice as a physician, is there any data that you think, man, I really wish I had that?
Lots of examples. One example that to me feels shockingly simple but is still challenging is around, and this might be a little US centric, but the cost of imaging.
Mm.
So if I send you to one imaging center that's maybe the most convenient for you, it might cost you 10 to 15x an imaging center that might require a 15-minute drive. And you may not know the costs of that. A lot of times people are separated from the true total cost of that imaging study based on just because there's insurance company in the middle of that decision making, but that information's out there. And so when I worked in the employer based space, I worked at a multidisciplinary primary care clinic on an employer's site, which was a lot of fun. And we worked with the third party administrator, the insurance provider, basically on site. Whenever we did an imaging study, we would just say, hey, what are their options that are close to work, close to home, and what's the true cost of that? And then we would work together to be like, hey, do you really need to get it at this place, or do you want to go to this imaging center that's maybe a little further away because it's cheaper? And that is, to me, a very low hanging fruit thing that we could do to save costs in the system. There are people that are focused on that, but still, there physicians that don't have that data right in front of them. I'm just thinking the small family practice, primary care practice. I
Mhm.
can't very easily say if I want to get a chest X-ray and I want to order this medication, which imaging center and which pharmacy is the cheapest place for you to get that same exact medication or that same exact service. So I think there's some of these data points this is not rocket science stuff that still is very challenging for a lot of physicians to get at their fingertips.
It makes sense. It would force a lot of competition and it would force prices down if that were the
Yeah,
case.
like GoodRx has been huge. I actually use GoodRx all the time. I'm not a shareholder or anything GoodRx, but these types of sites that have a lot of information that can show me for this specific medication, it might be better to send you to CVS rather than Walgreens or what have you.
Travis, thank you so much for your time. This has been really fun.
Sure. Thanks for having me, Patricia. I appreciate the conversation.
Thanks for listening. Before you go, a quick note about the company I co founded, Private AI. We help organizations use their data safely so they can build compliant AI products, share data securely, and extract insights without the regulatory headaches. If PII, PHI, or PCI data are standing between you and your next innovation, visit private-ai.com. See you next time on the Data Frontier.